All right, so in this lecture, we're going to talk about the anatomy and the function of the autonomic innervation of the organs in the thorax. So first, we're just going to go down the line of each organ. So first, we'll start with autonomic innervation of the heart. And we'll start here with the sympathetic innervation of the heart. So there's the cardiac plexus, which is a group of autonomic fibers. And we can see that here in the diagram here, and it's located in this region right here at the base of the heart, posterior to the aortic arch. And then what the sympathetic innervation specifically does is it helps control the heart rate and the force of ventricular contraction, which is physiologically defined as contractility. Now, one thing to be aware of here is during embryological development, the heart actually initially develops up here in the neck region, and then as the embryo develops, the heart descends down to its normal location in the chest. But by doing that, it actually drags these visceral nerves down with it. So as a result of that is you'll have the cell bodies, as we'll talk about in the next slide. They'll be in the thorax, in the thoracic region of the spinal cord, but then the fibers, the presynaptic fibers, will actually ascend up and then synapse in the cervical ganglion here, and then the postsynaptic fibers will actually come back down through the neck and then down into the heart and innervate the heart. So that's a reason why. That's something that may confuse someone when you're first learning this. But that's the basis behind that, is that embryologically it developed in the neck, so that's why there's certain fibers and nerves that go through the neck or come from the neck and then come down to the heart. All right, so we have this nice table in your book, and again, as we talked about throughout autonomic nervous system lectures, is it's all about location, location, location. Where is it? So the sympathetic innervation, we're going to go through the different components. So the presynapse neuron cell bodies, very, very important to know where those are. Where the synapses occur, where the postsynaptic fibers travel, and then what are the end-term effects of it. The cell bodies, probably the most important thing on here, is where the cell bodies are located. So they're in the lateral horn of T1 through T4. So it's always thoracic, so T1, 2, 3, and 4. So here are your cell bodies here in the lateral horn. Remember, it's that intermediate horn if we draw the spinal cord here. And remember, it kind of has this butterfly shape to it like this. And then you have the ventral horn here, the dorsal horn here, and then you have this kind of intermediate or lateral horn, and this is where our cell bodies are, okay? Then the synapse location, like I was talking about on the last slide, they're actually in the cervical ganglion, superior, middle, and inferior. So up in here, these portions up here or the thoracic ganglia of the sympathetic chain. So there's some fibers that go up here, and they synapse up here in the cervical ganglion, and then that's where those nerves come back down, and then they innervate the heart, and that's where that embryological origin of the heart comes into play, where it starts in the neck and descends down. Then there's also fibers, as you can see here, that synapse in the thoracic sympathetic chain, and then they go on to innervate the heart. The postsynaptic fibers, they travel, like we're saying, in the small cervical or thoracic cardiac nerves. So the cervical would be the ones that come from the neck. Thoracic would be the ones that come off of the sympathetic trunk. What are their effects? Like we said, for sympathetics, they increase heart rate and contractility. And if you remember, the sympathetic nervous system stimulates the fight or flight response. And so this is, a hyperactive state. You need to be able to, fight or run away. So increase skeletal muscle activity. So you need increased heart rate and increased contractility to get as much blood out to the systemic circulation as possible. Parasympathetic innervation. So it's provided mainly by the right and left vagus nerves, which give off cardiac branches that go to the heart. So if you look at here, it's labeled actually cranial nerve 10. That is the vagus nerve. So right here, this little blue line coming off here. Here's the cell bodies. The presynaptic cell bodies are located in the medulla, as you can see here. And then they travel down through the vagus nerve. And then, like all parasympathetic fibers, they synapse in the wall of the target organ. So they're going to come down in the vagus nerve, and then where this blue line represents its synapse here in the heart, in the wall of the heart. So what's the parasympathetic effects? Just the opposite of sympathetic, like in most cases. Decreases heart rate and decreases contractility. Now the vagus nerve it's responsible for regulating the resting heart rate. And so the vagus nerve, by default, it depresses the natural automaticity of the heart. So those, the conduction fibers, which we'll talk about in the next lecture for the heart, they actually are, innately, they generate the heart rate. So you have these cells here in the sinoatrial node or SA node, and these actually, without any input from the nervous system, they generate the heart rate by itself. Now, the problem is these generate the heart rate at a very high level, okay? So our resting heart rate, if you were to cut the vagus nerve in somebody, the resting heart rate would be a lot higher. And it would be just unnecessary. If you're sitting and resting, there's no reason to have your heart rate be 120 beats per minute. There's no reason for that. So what the vagus nerve does is when you're in your resting state is the vagus nerve actually depresses the natural automaticity of the heart. And so what that means is that it maintains the heart rate in a resting state at a normal, appropriate level. All right, so now we'll talk about the autonomic innervation of the lungs. So the lungs, their sympathetic innervation is provided by the pulmonary plexi, and it's labeled here bronchial plexus, same thing. It's located at the roots of both lungs, so that hilum. So if you look at, kind of the side of the lung, if this is like a side view, if you're looking this way and you have that hilum, you have the, the pulmonary artery, you have the bronchus, the pulmonary veins. There's also these nerves coming in at the hilum of the lung. It's directly continuous with the cardiac plexus, which is shown here, just inferior to it, and it also communicates with the esophageal plexus, which we'll talk about in a few slides here. Sympathetic and parasympathetic fibers from the plexi, they duly innervate the smooth muscle and glands of the bronchi, so that's the main thing, and then also the pulmonary blood vessels, so they're regulating blood flow to the lungs. Again, here's another one of those tables where we talk about the components and the effects. So, the cell bodies for the presynaptic neurons, pretty typical for sympathetic. For the thorax, it's going to be in these T1 through T4 levels of the spinal cord. So again, here, T1 through 4. Lateral horn, like we talked about, same thing with the heart. Synapse location, so these actually, they synapse in the upper thoracic chain ganglion of the sympathetic trunk. So they're in a synapse right here. Remember, the lungs, they develop in the chest entirely during embryogenesis. They're not like the heart where they start up in the neck. That's a unique thing to the heart. So for the lungs, there's no fibers coming up here into the neck. It's strictly in the thorax region. Postsynaptic fibers, they're thoracic visceral nerves to the pulmonary plexus. So you can see those here, and then this would be like the pulmonary plexus in here. The effects of the sympathetic innervation, again, this is the flight or fight response. So you want to bronchodilate. So if you have your bronchi like this, and you have your smooth muscle like this, so what they're going to do is you're actually going to relax this smooth muscle layer so that the lumen of the bronchi open up. Because if you're more active, you need more oxygen. So by increasing the diameter of the lumen of the bronchi, you're going to get more air in, more oxygen, able to run faster and run harder. Vasoconstrict, and then they decrease gland secretion. So the reason you want to decrease gland secretion is you have these glands kind of in here, near the epithelium, and they'll secrete these mucus secretions in here, and those plug up the lumen of the airway. And so you want to decrease secretion. You don't want to have a bunch of secretions here plugging up. You want this airway as open as possible when you're in the sympathetic state. Parasympathetic innervation, like the heart's provided by vagus nerve. Here's the presynaptic cell bodies located in the medulla here. Here's that vagus nerve, cranial nerve 10. So the fibers, like we said, right and left vagus nerves, they reach the pulmonary plexus directly off. So here's the vagus nerve coming off here. So this would be the pulmonary plexus. You'd have sympathetic fibers coming in and then parasympathetic fibers coming off the vagus nerve. And then, like we said, the cell bodies are in the medulla, and then the synapse occurs in the terminal ganglion of the walls of the bronchi and pulmonary vessels. So again, this is like all parasympathetic innervation, the synapse is in the wall of the target organ. Parasympathetic, they cause vasodilation and bronchoconstriction. So if you remember, the parasympathetic is rest, digest. Okay, so if you're resting, you don't need as much air. You don't need as much air because you're not moving. Your skeletal muscle isn't as active. You don't need as much oxygen, so you can afford to have a little bit of constriction. Now notice, bronchoconstriction doesn't mean you just close off the airway. It just means that you just narrow it. There's not you just narrow the lumen, so it's not as much air. There's enough air to get in. There's enough air to survive and be fine. You wouldn't notice any symptoms. In a normal person, when you bronchoconstrict in the resting state, it's totally normal. That you're getting enough oxygen, you will not know the difference. Then you increase the gland secretion. Same thing with this. You increase the gland secretion, but it's not to a degree where it totally plugs up the airways. Okay, that would be more infected or an asthma, other types of abnormal processes. Now, and speaking of abnormal processes, asthma, it occurs as a result of bronchoconstriction and then increased gland secretion as well. And that's what creates the obstructive lung disease. So in asthma, what you have here is you have these airways getting all, constricted by the muscles like this. You have your round muscle layer like this, squeezing in on the lumen. And then also you have, a bunch of mucus secretions in here as well. So it really tightens the airway a lot. And so that's why these patients, they become short of breath, they wheeze. So they need to be treated with bronchodilators. So the bronchodilators will act to either stimulate the beta-2 or sympathetic dilatory effects. So so these drugs, they either act to stimulate the sympathetic effects, which will bronchodilate, right? Or they inhibit the M2 receptors, which are parasympathetic receptors, and so they inhibit the parasympathetic bronchoconstriction. So you would either inhibit this contraction or stimulate sympathetic effects. And then also by doing this, if you were to give these drugs, you would also inhibit parasympathetic stimulation of gland secretion as well. All right, so now we're moving on. We'll talk about the autonomic innervation of the esophagus. So here, this table again, the components for the sympathetic innervation. The heart and the lungs have a good anatomy component, good physiology concepts to know and understand. The esophagus is much more low yield. We just want to get this through so that in case an anatomy exam tests you, this is not very high yield for a board exam at all. This is more just an anatomy exam. So if you're studying for the board, you could almost just skip this section if you want to. But if for an anatomy course, you might want to pay attention just in case these are on your test. So the presynaptic neuron cell body is just like the heart and the lungs, T1 through T4, lateral horn here, right here. Synapse, sympathetic trunk ganglion, so in here. Here's your esophagus right here, just above your stomach there. And so the postsynaptic fibers are going to be these thoracic visceral nerves, the esophageal plexus, just kind of like how there were, visceral nerves to the lungs. The effects, vasoconstriction. So the sympathetic innervation isn't too significant, the actual effects on the esophagus. It just will decrease blood flow. That's really all that's, important to remember about that. Parasympathetic innervation is much more important. The esophageal plexus is formed by the right and left vagus nerves. You can see the esophageal plexus in here. And then it supplies the lower 2/3 of the organ, since the upper 1/3 is skeletal muscle. So that's more somatic innervation. So the right vagus nerve, it passes on to the posterior esophageal surface, as you can see here. So it goes down, it forms, and I know we talked about this in the posterior mediastinum lecture. This is just a quick review. And then it exits through the diaphragm posteriorly as that posterior trunk. The left vagus nerve goes onto the anterior surface. So here's the left vagus nerve. It comes down, travels on the anterior surface, goes through the diaphragm. And the parasympathetic stimulation, so here's the important part, produces that rhythmic contraction of the esophageal smooth muscle involved in peristalsis to propel the food into the stomach. So the parasympathetic innervation is what drives the peristalsis to help you digest. Again, remember, rest and digest. Now we'll very briefly talk about the thoracic splanchnic nerves. Here we're just going to kind of introduce you to them so you know what they are. We're going to talk much more about their function in the abdomen lecture because their function is more relevant to the abdominal organs. So overview, what are they? They are nerves that are direct branches off of the sympathetic trunk. For this reason, since they branch off in the thorax, the other reason we want to talk about this is if you're doing a cadaver-based course, these could be tagged in a practical, so you want to be aware of this when you're dissecting. You want to try to find one of them on one of the bodies in the lab so you don't get tripped up on a practical exam. So what do they serve to do? They provide the autonomic innervation for abdominal organs. They actually don't really do anything in the thorax. Even though they travel there, they don't have any significant effect. They carry sympathetic, so a good practical question would be they tag, kind of a secondary question, they tag one of these nerves and they ask you what kind of nerve fibers run through these nerves. And so the answer to that would be sympathetic, preganglionic, or presynaptic, general visceral efferent fibers. And so the cell bodies for those are located in the lateral horn of T5 through T12, so down in this region right here. And so that's different than in the thorax. All the thorax ones for heart, lungs, esophagus, they were all located in T1 through T4. These ones, T5 through T12. And then the visceral afferent fibers, these will also be traveling through, but their cell bodies are going to be located in that dorsal root ganglion. So like many nerves, it has the visceral afferent fibers, which are coming from the organs, bringing sensation to the spinal cord and the brain. And then also it has efferent fibers, which are coming from the spinal cord and then going out to the organs. So there's the greater, the lesser, and the least splanchnic nerve. Here we'll talk about the greater splanchnic nerve. This nerve, actually, it's formed by branches off of the T5 to T9 sections of the sympathetic trunk, so kind of in this region here, and you can actually see it here. And so these fibers will all come off of, all come off of these regions, these levels of the sympathetic trunk, and then form one nerve that goes out like that. Then it passes through the diaphragm into the abdomen, and then it ends in the celiac ganglion, which you can also see in this region right here around where the celiac trunk comes off the aorta in the abdomen. The lesser splanchnic nerve is formed by branches from the T10 to T11 sympathetic trunk ganglion, so a little bit farther down in this region here. And those come together, and then they pass through the diaphragm into the abdomen and ends in the aortico-renal ganglion. The least splanchnic nerve, this branches directly off the 12th section of the sympathetic trunk, so in this region right here, and then passes through the diaphragm into the abdomen and ends in the renal plexus. So again, we didn't really go into much detail about these. It's much more important for the abdomen lecture. We just wanted you to be aware of these, what they are, know that they travel in the thorax, and then know that if you're taking a cadaver-based course, they could be tagged on a practical. All right, so we're going to close this out by talking about one of my favorite topics in pathology and physiology and anatomy is a Pancoast tumor. Unfortunately, like many things in medicine, the most interesting things are often the most devastating things. This is a very devastating tumor to have, and with not a really great prognosis, but it has, because of its nature, it has some very interesting anatomy and physiology tie-ins that end up making it very high yield for a board exam, and often it's tested on anatomy exams as well, and it helps you understand the anatomy and the spatial relationships a lot better. So that's why we're going to spend a little bit of time talking about this. So what exactly is a Pancoast tumor? A Pancoast tumor is a malignant tumor. It's a cancerous tumor. It's defined by its anatomical location, which is in the apex of the lung. If you remember, this is the apex. So here's the tumor. Here's the Pancoast tumor in this coronal CT, this big gray ball here. So it's not a histological diagnosis or definition, unlike most other tumors in pathology, which are defined by their histology. Now, if you get asked about the histology, though, of the tumor, a Pancoast tumor, if you remember for lung cancer, there's two types. There's small cell and then non-small cell, okay? This is a non-small cell lung cancer, and it's usually often squamous cell carcinoma. So if you get a board question, let's say someone throws up a image of this on a board question, and they ask you what's the most likely, remember, often board questions will ask you what's the most likely, okay? What they mean by that is not what it is 100% of the time, because usually something is never 100% of the time. They're asking what's the most likely, what has the highest percentage, or what's the highest percentage of cases, is basically what they're asking you. And so if they say if it's a Pancoast tumor, what are most Pancoast tumors? Well, if you just look at the data, most Pancoast tumors are squamous cell carcinomas, okay? So that would be the right answer. Just keep that in the back of their mind, because that could be a board question or a question on an anatomy exam, is what's the most common histological class. Now, what happens here is due to the location being in the apex and near the ribs, it usually invades adjacent ribs. So you can actually see that here where it's invading ribs here, and it also invades vertebrae as well. So there's often a very multidisciplinary team that gets involved in treating these tumors for this region. Because it's in the thorax, you usually have a thoracic surgeon involved. If it invades the vertebrae, you have a spine surgeon involved. Obviously, you can have radiation oncology, medical oncology is involved. So these are very complex tumors that need a lot of different specialties to treat them. So given that since it's a lung cancer, the presentation, it's usually just the non-specific symptoms of lung cancer: fatigue, malaise, weight loss, coughing a lot, hemoptysis, coughing up blood. But however, these are what are more unique to a Pancoast tumor. Now, because of the location, shoulder pain is often very common. So if someone's a long-time smoker and they come in with shoulder pain, it's something you might want to keep in mind that they have a Pancoast tumor, possibly rib pain, and then back pain as well, especially if there's a vertebral invasion. So what do you treat it? Just like most cancers, you can do chemotherapy, radiation therapy, and then surgical resection of the tumor, and then structures it is invaded. So these tumors, that what makes them, and we'll talk about in the next couple slides, what makes them interesting from an anatomy standpoint is the nearby structures they invade. And so unfortunately, a lot of times you would have to resect any structures that it invades as well to give the best prognosis. So the complications, this is where it usually comes into play for test questions, and then why it's anatomically relevant. So classically, a Pancoast tumor, due to its proximity to the vertebrae, will invade the sympathetic trunk. So if you look down here, here's the sympathetic trunk traveling here on either side of the vertebrae. Now, since this sympathetic trunk traveling in the thorax is right near the apex of the lung, so if you have your apexes of the lungs like this, you have your vertebrae coming down like this, here's your vertebral bodies, and then you have the sympathetic trunk kind of traveling down like this. If you have a tumor up here in the apex, it can very easily invade into the sympathetic trunk. Now, what does that do? It destroys the sympathetic input to the head and neck, because you have these fibers, as you can see here in red, and they come down and they travel in the thoracic ganglion, but then they ascend up the trunk and go into the head and the neck. And what they end up causing is something called Horner syndrome, and Horner syndrome has three parts to it: ptosis, anhidrosis, meiosis. And then the way you can remember that is PAM, as you can see in the red letters we've highlighted here. So what exactly does this mean? So if you have a tumor that comes in and it invades the thoracic portion of the sympathetic trunk, you're cutting off this input of these fibers that ascend up here. So these fibers, what they do is they ascend up here, and what are they going to do? They're going to innervate sweat glands. So there's some fibers that are going to come off here, and they're going to innervate sweat glands. So for sympathetics, these sympathetic fibers are going to stimulate sweat glands, okay? And then the other thing they're going to do is they're going to come up here. They're going to innervate a muscle called the superior tarsal muscle, which is a muscle located in your eyelid, okay? So you're going to have your eyelid that comes down like this. So it's going to innervate, the fibers are going to innervate this as well. They're going to stimulate that, which what that does is by the muscles, and remember, just like any muscle, they contract, it's going to pull the eyelid up that way. And so it's going to, help you keep the eyelid open, keep your eyes open, okay? So as you can see here, these fibers, they come up here and they innervate a muscle called the dilator pupillae muscle, as it's labeled here. And so what you have here is your pupil, which lets, light into your eye so you can see. And so you have these, circular muscles around here like this, which is the dilator pupillae. And so when you have sympathetics that come in, they stimulate this muscle to allow dilation of the pupil. So you widen the pupil so that more light can come in. So the idea is that when you're in the dark, it stimulates dilation of the pupil so you can let more light in, so you can see better in the dark. So you can run away better in the dark, you can maneuver better in the dark. It's a survival tactic. So now that I've given you all the three normal effects here: sweat glands, sympathetics stimulate sweat glands, they stimulate the superior tarsal muscle to elevate the eyelid and let you open up and see, which again, you need to see to survive. And then they also stimulate this dilator pupillae muscle, which helps dilate the pupil so more light can come in, you can see better, maneuver around better. Now the problem is, if this tumor comes in and blocks these inputs, so you're blocking the sympathetic input. So you're going to lose stimulation of the sweat gland. You're going to lose stimulation of the superior tarsal muscle, and then you're going to lose stimulation of the dilator pupillae muscle. So what does that result in? If you don't stimulate the sweat glands, you're not going to sweat, and your skin's going to get dry. That's what anhidrosis means, okay? Then you come in, if you don't stimulate the superior tarsal muscle, you can't lift up your eyelid. So your eyelids actually, so if you have your eye like this, the eyelid is going to droop down like this. It's called droopy eyelid, which is called ptosis. So you're going to have ptosis. So you're going to have a droopy eyelid, you're going to have dry skin, and then the third thing is meiosis, which is constriction of the pupil, okay? So by losing stimulation to this dilator pupillae muscle, you can't dilate these people, they can't dilate their pupil. And so what happens is that remember that muscle equilibrium. It's a balance in this case between the sympathetic and the parasympathetic fibers. So if you lose that sympathetic input, the parasympathetic fibers are going to take over, and the parasympathetic fibers actually stimulate constriction of the pupil. So you're going to have constriction of the pupil, narrowing of the pupil. So these people have, again, they have ptosis, droopy eyelid, anhidrosis, which is basically dry skin, and then they have meiosis, which is constricted pupils. So these are the three things you want to be aware of. And it all stems from the tumor invading the sympathetic trunk in the thorax region and then blocking these sympathetic fibers coming up and stimulating these effects. And so one thing to be aware of, just to close this out, is that it's on the ipsilateral side. So if you have a tumor invading the sympathetic trunk on the right side, all these effects, they're only going to occur on the right side. If it's a tumor on the left side, these effects are only going to happen on the left side. Because remember, as you can see here, you have two sympathetic trunks. The right sympathetic trunk controls the right side structures. The left side sympathetic trunk controls the left side structures. So if you have a tumor, so it's important to know this is not going to be a bilateral presentation. So they're only going to have ptosis in one eye. They're only going to have meiosis in that same eye, the affected side. They're only going to have dry skin on the affected side. It's important to know it's not a bilateral. If someone comes in with bilateral ptosis and meiosis, that's more likely, something in the central nervous system, in the brain or the cranial nerves, and that's more of a neuroanatomy or head and neck thing that we'll talk about in Chapter 7. Some other complications that can happen. So if you have a tumor here in the apex of the lung on this side, it's right near the brachial plexus. So in addition to invading these sympathetic inputs, they can also invade the brachial plexus. And what does that cause? Again, it's only on one side. It's not, if you have bilateral weakness, it's more likely a central nervous system problem. So in this case, it's only affecting one side. So it's going to cause ipsilateral weakness of the arm and the hand, because remember, the brachial plexus is involved in innervating the upper extremity. So what these patients could present with is they could have Horner syndrome and hand or arm weakness. They could have, a common thing would be if it invades the brachial plexus, they'd have shoulder pain, intrinsic hand weakness because of the brachial plexus, and then they could also potentially have Horner syndrome. Another thing to be aware of is that the larger tumors, if it gets really big, it can actually grow in and obstruct the superior vena cava, leading to SVC syndrome, which is where you have huge backup of blood into the brachiocephalic and subclavian and axillary veins up into the internal jugular and external jugular veins. So you have these thick veins in the neck and arms and real puffy looking skin. That's more, you don't see that. You can see that with a Pancoast tumor. That's why we mentioned here. It's more common to see with other tumors. So what would be a classic presentation? A classic presentation in an exam would be a patient with a long history of smoking. Usually these are tumors in smokers. That's usually what happens. It's someone who's been smoking for 30, 40 years, and they've developed this tumor, and unfortunately the tumor develops in the apex of the lung, and that makes it a Pancoast tumor. And so what do they present with? They present with often chronic coughing, plus or minus hemoptysis. They could be coughing up blood, not necessarily. They could have shoulder pain because of the location of the tumor in the upper region of the thorax and the shoulder region, especially if it invades into the shoulder region itself, the brachial plexus. And then very often Horner syndrome, especially on a boards question. If someone comes in with lung cancer symptoms and they have Horner syndrome, it's almost always a Pancoast tumor. There's really not anything else it could be. So that's going to be your huge tip-off. The way you are able to identify these tumors is the two real big things is you want to be able to spot out Horner syndrome, which we went over in the last slide, your ptosis, your anhidrosis, and your meiosis. And then you want to it's all about context. If it's in the context of someone with a smoking history, they're coughing, risk factors for lung cancer. And then the other thing is you also want to be, as we show on this slide here, you want to be able to know, spot this on a radiograph, because you could see this on an exam. So you want to be able to identify this as well. And that closes out our discussion of Pancoast tumors and the autonomics in the thorax. Now we're going to move on to the heart.